Thank you. Our next session will be on structure function correlation in glaucoma. Over to you, Dr. Manju M.
Good morning all. Welcome to our session. Our first topic will be by Dr. Manju R. Pillai Madam. She's a glaucoma consultant in Arvind, Madurai. She will be discussing the protocol for management of childhood glaucoma. Over to you, Madam.
So, good morning to all of you. And primary objective is to normalize and permanently control the intraocular pressure by preventing loss of visual acuity, preserving visual field and ocular integrity, and to stimulate the development of binocular stereoscopic vision. And here is a small video. And the incidence of childhood glaucoma is 2.29 per 1 lakh population and occurs in about 1 in 10,000 births.
Childhood affects 1 in 15,000 live births. The Childhood Glaucoma Research Network, composed of clinicians and scientists in collaboration with the World Glaucoma Association in July 2013, developed a new classification system for childhood glaucoma.
So this classification is in place for the past 20 years.
Childhood glaucoma we mainly classified primary childhood glaucoma and secondary childhood glaucoma. Primary childhood glaucoma is further classified into primary congenital glaucoma and juvenile open-angle glaucoma. Primary congenital glaucoma is subcategorized based on the age of onset as neonatal, infantile, and late. Secondary childhood glaucoma is classified into glaucoma associated with non-acquired ocular anomalies, glaucoma associated with non-acquired systemic anomalies, and glaucoma following cataract surgery. We have classified the protocol based on the age of the child, that is, for infants less than 1 year and for children more than 1 year. For infants less than 1 year of age, initially vision assessment is done. A detailed history, including the antenatal history, the birth history, postnatal history, family history, pedigree chart, and past medical and surgical history are noted. Intraocular pressure is checked by the eye care tonometer, and a preliminary examination is done by a torchlight or a portable slit lamp, followed by documenting a clinical photo. For children more than 1 year of age, vision assessment is done initially and can be classified as children with clear cornea and children with a cloudy cornea. In children with a clear cornea, refraction is done, followed by history documentation, whereas in children with a cloudy cornea, directly history documentation is done, as refraction cannot be performed in these cases. After taking history and the intraocular pressure measurement, the axial length is measured, followed by ocular examination by torchlight or a portable slit lamp or slit lamp examination, depending on the child's cooperation. So how frequently should the axial length be checked? It has to be checked every 6 months for children less than 5 years of age and every year in children more than 5 years of age. How frequent should we check the intraocular pressure? The intraocular pressure has to be checked every visit as it plays a key role in deciding the management. Essential elements in a review case record include the visual acuity, refraction, intraocular pressure, ocular examination, and axial length measurement whenever necessary. For the required children, low vision assessment is done and any other investigations like B-scan or UVM are performed whenever necessary or whenever indicated. A final examination is then done by a senior glaucoma consultant and a pediatric ophthalmologist, and the management is done either medically or a planned examination under anesthesia is then done. Counseling is also done to explain the parents regarding the disease and the importance of medical management. And also, sibling counseling is emphasized. A detailed systemic examination is performed and a pediatric referral is also done if necessary. For children with amblyopia, a pediatric ophthalmologist consultation is done and patching is followed as advised. Low vision assessment is also done whenever required for certain children. For infants from 0 to 6 months who have visual potential of fixing and following light, torch light with color balls and running light are used. For infants who cannot fix the light, color balls and running lights are used for vision stimulation. For children with age more than 1 year, vision stimulation is enhanced by picking object activities and assessment is done using teller acuity, Lear grating and hiding. If the child is special, then only Lear grating and hiding are used in the assessment. For children more than 5 years of age, hiding and pelidopsin chart are used. The children are trained in a child-friendly environment to walk independently. The Vikas app is also used to understand the level of understanding of the child and also helps in assessing the child's ability and the areas in training. Digital magnifiers can be used to enhance the reading ability of the child. The recent developments are the smart vision glasses. This is a wearable device which works on artificial intelligence, machine vision and machine learning and helps in facial recognition, provides walking assistance, reading assistance and also to understand the surrounding things.
So that was about the clinical examination. In the surgical management, surgery is the mainstay of treatment and the first chance of surgery is often the best chance. But glaucoma surgery in children is very challenging than adults. The angle surgeries that we do are either goniotomy or trabeculotomy. The challenges being distorted limbal anatomy, thin elastic sclera, and there is predisposes to a leakage around the tube when we do it because it's a ophthalmic eye. Distortion due to previous surgery is also a challenge. Aggressive healing and inflammatory response in children is more because of the thick tenons capsule. And anatomical fractures like thick tenons and fibroblasts lead to scarring. Post-op follow-up, there can be a lack of cooperation and we need to even have long-term visual outcomes after the surgery, that is emmetropic correction and amblyopia management. So surgeries for childhood glaucoma that we do is initially we try trabeculotomy or in advanced cases we try combined trabeculotomy plus trabeculectomy. And then we try tubes in refractory glaucomas or even if the first surgery fails. When there is a limited long-term success, we do diode CPC. And sometimes if a visceration is required, if the child is big enough, we take the consent of the child if possible. Informed consent needs to be obtained for examination of surgery and general anesthesia. An ideal time to record an intraocular pressure is prior to the administration of an inhalational general anesthetic. Accurate measurement of IOP is the basic requirement for diagnosing and monitoring therapy of childhood glaucoma. And measuring the intraocular pressure is a challenging task in children. So preoperative considerations that we need to look for in healthy children, it's not very much, but children with chromosomal or metabolic disorders, there is an anesthetic challenge and there is a post-op follow-up that needs to be planned. Preoperative medications should be very carefully because ocular cardiac reflex may be induced during an eye surgery which provoke dangerous bradycardias. This can be prevented by pre-medicating with anticholinergic agents. So the anesthetist needs to be informed in prior on what are the medications that we are using for the child even if topically. The fasting guidelines, less than 6 months is 3 hours fasting. 6 to 36 months, it's 4 hours fasting, and more than 3 years, it's 8 hours fasting. And this is a very small video on how we do a trabeculotomy. We cut the conjunctiva, including the tenons, but we don't give an antimetabolite when it's a plain trabeculotomy. We cauterize the vessels and take a triangular flap. Identifying the correct anatomy is very important while doing a trabeculotomy because we don't need to reflect the spiral flap till the limbus and it's a distorted anatomy, so the Schrems canal is a little posterior. So as the textbooks has described, the blue meets the white and that's where we need to keep the incision. The seepage of aqueous is enough to put in the trabeculotome. If there is a gush of aqueous, then we can be sure that we have entered the anterior chamber. So this is very important. Yes, then the aqueous has come out, and then identifying the correct part is important. So challenges in the post-op or post-operative urgent measures like suture removal or an anti-scarring agent like 5FU is difficult, and caregivers' commitment to post-op regimen is very important. The medications that can be absorbed through the pharyngeal mucosa via the nasolacrimal ducts are timolol or betoxolol. So this can cause bradycardia while giving GA. And carbonic anhydrase inhibitors, long time back they were using half diamox as crushed tablets for the babies. This can give rise to metabolic acidosis and electrolyte abnormalities. So anesthetic agents that can affect on to the intraocular pressures are propofol can reduce by 30%, opioids minimal effect, atropine no effect, ketamine dose dependent increase in IOP. So what we use are sevoflurane, and intravenous anesthesia can be either propofol or ketamine. So ketamine is the second leg of choice for EUA, and the EUA set includes checking intraocular pressure, corneal diameter, refraction, anterior segment examination, gonioscopy, fundus evaluation, corneal thickness, B-scan, and UBM. Thank you.
Thank you, madam, for that enlightening talk. We will keep the discussion to the end.
Yeah, I'm leaving. Thank you.
So any questions anybody has regarding the childhood glaucoma?
So if you want to have an elaborate discussion on childhood glaucoma, please attend our conference in Madurai in December 12th and 13th. That will be the best.
Okay, ma'am. Thank you, ma'am.
We now request Dr. Manju R. Pillai ma'am to collect memento from Dr. Manju M.
Next talk is by Dr. Maya TJ. She is working as glaucoma consultant in Little Flower Hospital, Angamali. She will be talking on catching structural loss before functional field speaks. Over to you, Dr. Maya.
Good morning all. I am presenting on silent signals catching the structural loss before the visual field speaks. Glaucoma is characterized by progressive dysfunction and degeneration of retinal ganglion cells, resulting in structural changes to the optic nerve head and inner retina with accompanying visual loss. The key to glaucoma diagnosis is recognition of the morphological changes to the optic nerve head and retinal nerve fiber layer that result from retinal ganglion cell loss. Assessment of visual function is also central to glaucoma diagnosis, with the prevailing test being standard automated perimetry. Visual field tests are occasionally unreliable, which impairs its diagnostic efficacy. Glaucoma structural changes are typically detected using slit lamp fundoscopic examination or by observing for changes on stereophotographs, with features including narrowing of neuroretinal rim, increased optic nerve head excavation, increased cup to disc ratio, diffuse and localized loss of RNFL. Although the diagnosis of glaucoma is often straightforward, detection of early glaucoma can be challenging due to the wide variation in normal optic nerve head appearance. Subjective interpretation of the optic test stereo photographs are also subject to variation between the observers. Therefore, more objective and reproducible methods are required for assessing peripapillary and macular structural changes in glaucoma, which shows a promise as a biomarker of early glaucomatous damage. Glaucoma diagnosis and monitoring requires both structural and functional analysis. The introduction of ocular imaging devices such as OCT, CSLO and SLP has helped obtain objective quantitative measurements of ocular structure and can detect glaucoma at an earlier stage. In addition to evaluating optic nerve head and RNFL, this also evaluates the inner layers of the glaucomatous macula. Also, imaging devices contain normative data that allow one to determine the probability that observed measurements are within the normal range and to potentially detect glaucoma at an earlier stage. Although in some cases, functional changes may be detected before structural changes, the earliest detectable manifestation of glaucoma for many patients is an abnormality of the optic nerve head or RNFL. Pre-perimetric glaucoma is characterized by structural optic nerve abnormalities consistent with glaucoma with no evidence of visual field changes with standard automated perimetry. This figure shows the retinal nerve fiber layer thickness outside normal limits in the right eye and borderline in the left eye, while the 24-2 standard automated perimetry shows glaucoma hemifield test within normal limits in both eyes, in the right eye. Slit-lamp biomicroscopy. Stereophotography of the optic nerve head and RNFL remains the most valuable and widely available method to identify the glaucomatous optic neuropathy and to detect structural changes over time. This is used to document structural abnormalities and longitudinal changes in glaucomatous eyes. It is highly reproducible and records a normal, natural color image of the retina. In OHTS, only 12 of 125 eyes that develops glaucoma during follow-up had a visual field and structural endpoint detected concurrently, meaning that there was often disagreement between the tests. 69 eyes had an optic disc endpoint first and 44 a visual field endpoint. So in ocular hypertension treatment study, more eyes might have reached a structural endpoint if SDOCT measurements rather than optic disc photographs has been the chosen method of detecting the structural change. Coming to OCT, it is an imaging technology that measures intensity and echo time delay of backscattered and back reflected light from the scan tissues. It provides a high resolution cross-sectional images of ONH, RNFL and macula. While analyzing an OCT RNFL printout, first assess the quality of the scan, whether the signal strength is more than or 6 is acceptable. See the centration of the disc, look for artifacts. Then this area compares the normative database, which the OCT provides normative data for disc area of 1.3 to 2.5 millimeter square. This shows the RNFL thickness map. The 0 micrometer thickness is represented by black color and 350 micrometer as white. The RNFL deviation map compares cluster of pixels in the test image with a normative database. These are the NRR thickness graph and the TSNIT RNFL thickness graph, which normally has a double hump pattern which is lost in glaucoma. These are the quadrant maps which provide average thickness in each quadrant compared to the normative data and the Glaucoma maps. This part shows the B-scan images with look for the proper placement of the demarcation lines. This picture shows the segmentation error and these are the pano map. In addition to measuring average circumambulatory RNFL thickness changes, it is also important to consider localized RNFL loss, in particular in the supratemporal and the infratemporal sectors, which are the most frequent regions affected in early stages of glaucoma. Confocal scanning laser ophthalmoscopy is a rapid, non-invasive, non-contact imaging used by Heidelberg retina tomography, producing a 3D image of the optic nerve head. It takes a series of 32 confocal images and it converts into a single topographic image. Then the operator indicates the optic nerve contour line over the topographic image. This is the HRT printout, which shows the cup section represents the disc topography. The cup parameters are shown in the row are cup disc area, ratio and cup shape measures. Then comes the rim area measurements and the RNFL measurements. This topographic image in the HRT gives a color coding for the cup and disc. The red one shows the disc cup area and the blue one shows the sloping NRR rim and the green one shows the non-sloping NRR rim. It gives the disc size also. Then it gives a reflection image. This is a reflection image which is valuable in locating and drawing the contour line around the disc margin. Then it also has a HRT3 also provides glaucoma probability score, which is a new software and based on construction of a 3D model of ONH and RNFL. by using 5 parameters: cup size, depth, rim stiffness, horizontal and vertical RNFL. HRT can differentiate between normal and early glaucoma size with a sensitivity of 79 to 87% and specificity 84 to 90%. Scanning laser polarimetry is an RNFL analyzer which is based on the principle of birefringence. This is used by the GDX machine. This is the GDX printout. Coming to ganglion cell complex, as the macula contains approximately 50% of retinal ganglion cells, glaucomatous damage might be more readily identifiable in this region. The GCC comprises of RNFL layer, ganglion cell layer, and the inner plexiform layer. Several studies have shown ST-OCT macular GCC measurements to have similar ability to detect glaucoma as circumpapillary RNFL. Then the last one is the OCT angiography. This technique, it is a technique that can measure numerous quantitative vascular parameters such as vessel density, blood flow index, parapapillary deep layer microvascular dropouts. Few studies have demonstrated that the values of these vascular parameters have become lower than within eyes of mild, moderate and severe glaucoma as compared to the non-glaucomatous eyes. This picture shows the peripapillary vascular density, then the vascular density inside the disc, then foveal avascular zone, parafoveal vascular density, and this one shows the more vascular dropouts and less vessel density. So to conclude, although histological studies have suggested that large number of retinal ganglion cells may be lost before one would expect to detect a statistically significant defect on automated perimetry, some studies have shown that first manifest sign of glaucoma may be either a structural or a functional loss, and therefore early diagnosis depends on testing both the domains. The relationship between structural and functional damage is not fully understood, and particularly in early disease, there is often apparent disagreement between the measurements. So we have to before making a diagnosis, it should be a multimodal approach with clinical, imaging and the perimetry. Thank you.
Thank you, Dr. Maya, for that wonderful talk. Next, I invite Dr. Manju M. She is a glaucoma consultant working in Arya High Hospital, Thrissur. She'll be talking on false alarms, early misses, visual field limitations in early glaucoma.
Good morning all. The talk is on false alarms and early misses, the visual fields limitations in early glaucoma. So we'll start from what is glaucoma. Glaucoma is defined as a disturbance in the structural or functional integrity of the optic nerve that can usually be arrested or diminished by adequate lowering of the intraocular pressure. So for the diagnosis of glaucoma, we should have a structural, that is the optic nerve head analysis and the OCT analysis, and also the visual functional analysis is by the visual field analysis. The functional analysis is usually by the visual field analysis, and a normal visual field is defined by TACWare as an island of vision surrounded by a sea of darkness. It is 60 degrees superiorly and nasally, 70 degrees inferiorly and 100 degrees temporally, and the blind spot is located 10 to 15 degrees temporal to the fixation. So usually done by the perimetry, that is systematic measurement of the visual field, by the standard automated perimetry or white on white perimetry. So when you do a perimetry, there is a fixation target, usually a central fixation target. And if you don't have a central fixation in such patients, you can see a small diamond there. So you can tell the patient to focus on the center of the 4 points of the small diamond, or even there's a peripheral large diamond also. And usually we use SITA standard, Simulus 3 white with fixation target center. You have other options like SITA fast, which is a quicker method, and also even SITA faster method. So you do what usually is a 30-2, which has 76, which tests 76.6 degrees apart, and then 24-2, which we usually do in glaucoma, which tests 54.6 degrees apart. And 10-2, which has more points, like 68 points, 2 degrees apart, which focus on the central area. And if you are planning any surgery, better to do a macular program with 16 points, 2 degrees apart, to see whether there is any macular split or split. And for those who we are suspecting any central field defect, you can do a 24-2C, where 24-2 is with an additional 10 central test points. That is the 24-2C. And this is how the HFA report is. And now we have short wavelength automated perimetry, which is a blue on yellow perimetry, which can dictate early visual field loss before standard white on white perimetry. Now, what are the early, now we are dealing with the early glaucomatous field defect. It can start with a nasal step. Here you can see, here it is 0 and it is 19. So there is a difference in the nasal side, that is it's a 24-2 field, but the nasally it is up to 30-2. So here, sorry, 30 degrees. So here there is a dip. So it is a relative depression of the horizontal hemifield compared to the other. That's an early glaucomatous field defect, is a nasal step. And you can have a small island of relative or absolute vision loss in 10 degrees, central or paracentral scotomas. And this is like almost like an early arcuate scotoma, but usually arcuate scotoma start from the blind spot like this. If you have an arcuate scotoma, it's not an early glaucomatous defect. It comes as more like an advance. Starts, it's an arcuate scotoma that starts from the blind spot, arches above or below the fixation, and reaches within 1 degree of the fixation, and it can extend up to nasally up to 20 degrees. But it does not cross the horizontal divide. That is the most important thing. So coming to the topic, the visual fields, what are the visual fields limitations in early glaucoma? One thing is that in early glaucoma, patient can have high test retest variability, because the patient is having a learning effect. And there can be a structural damage often that precedes the functional damage. Same as I mentioned, there can be a learning defect that can cause false progression or more false positive or false negative effects. And there can be localized early defects which can be missed on if you do only a standard 24-2. There can be defects that is closer or central area which can be missed in 24-2. And there can be patient related factors like which can reduce reliability in early disease. So this is like a generalized depression. You can see in the total deviation plot there is depression, but the pattern deviation plot, which is more specific for glaucoma, is okay. So if you only focus on this total deviation plot, it's like a false alarm. And here you can see a dense defect present in the contagious region or peripheral region, like a rim. This is due to the lens rim artifact. The trial lens which we use for the HFA is causing a rim artifact, which will be seen as a peripheral damage. It's like a false alarm. And here you can see the patient is having a high false negative errors. And because of that, that is 80%, because of that you see a clover leaf pattern. And it's due to the patient inattentiveness. But if you are not careful, it will be like a false alarm. You may think that the patient is having glaucoma and proceed with the treatment. And you can have like white scotomas if there is high false positive error, as you see here. And if you have high false positive errors, there is a chance of missing field defects. So it's like maybe like an early miss where you may miss genuine field defects. And this case, this is a 68-year-old patient who was on AGM in the right eye. But the left eye patient was not on any anti-glaucoma medication because everything seemed to be normal. But if you see here, if you incorporate that with the structural damage, that's what we are stressing. You can see a RNFL loss in the superior part of this OCT. And definitely if you observe, you can see a small slit-like RNFL defect in the patient. So if you only focus on the visual field, this is like an early miss. And this is also a 70-year-old patient, not on any anti-glaucoma medication, and it was like a borderline defect. But if you see the OCT, you can see there is a definite inferior RNFL loss with a wedge-shaped RNFL thinning. So this is or like a pre-perimetric glaucoma only if you incorporate the OCT and correlate structure and function, then only we will be able, otherwise we will be, it's like an early miss. This also field is completely normal, but here is a small defect, RNFL defect, and you can see it's not that visible, but there is a small RNFL, wedge-shaped RNFL defect in the optic nerve. So we are not saying you should start the treatment or anything, but in such patients, you can follow up the patient more frequently, and you can tell the patient there is a chance of a glaucoma and follow-up is needed. And in this patient, the patient is having a small nasal step-like defect, but structurally, if you see, there is no RNFL defect. The ganglion, GCC also normal. CCT is 544, so everything is normal. This is due to the high false negative errors. It's like a false alarm. If you see only the field defect, it seems like a nasal defect. This patient was frequently having superior field defect, but the structural loss was not corresponding to the visual field defect. The patient was having a ptosis. So because of this ptosis, patient was having a superior field defect. So it was like a false alarm. So how to rectify this? Better to have the structure function, always correlate structure with function. Repeat baseline field, supplement if 24-2 you are taking, and if you see any field defect in the OCT, better to do a 10-2 also, and always optimize patient factors like dry eye, anxiety, refractive error, and also do multiple tests and analyze progression if you have any doubt. So I'm just telling the structure function correlation. Here, if you have any field defect, this is the area where there can be a field defect by the structure, and if you see the same in the field defect, this is like a structure function correlation. So we'll move to the last. So this is like a visual field. It's a baseline visual field. If you repeat it, the field is normal. So this was like a learning effect. So to conclude, the take-home messages will be like false positive fixation losses and learning effects can reduce the reliability of the visual field. So structure function correlation is mandatory. So if you see any central macular defects, better to do 10-2. Multimodal imaging is important. Repeat testing and to improve the reliability, and you can have AA enhanced techniques also. Thank you.
Thank you, Dr. Manju, for that excellent presentation. Now, I invite Dr. Soumya PP. She's working as a glaucoma consultant and phacosurgeon at Comtrust Eye Hospital, Talasheri. She'll be talking on the tipping point, decoding the lag between nerve loss and vision loss.
A very good morning to everyone. My topic of discussion is tipping point, decoding the lag between nerve loss and the vision loss. What is it? First, we have to understand what is tipping point. Why the nerve loss shows long before the vision loss. The retinal ganglion cells, as you know, and their axons begin to die early. But yet the patients continue to see normally, sometimes for years. Eventually, a point is reached where vision suddenly starts to deteriorate. This delay is known as structural functional lag, and the moment vision finally declines is called the tipping point. So this is it. Biochemical changes comes, then the structural changes comes, then the functional changes comes. Why does this lag happen? What is the cause? There are many causes for this redundancy in the visual system. As you know, the eye contains about 1 to 1.2 million optic nerves, and you don't need all these for the normal vision. So in the earlier loss, the system compensates for it, and the later nerve loss, the compensation fails and the vision loss emerges. And think of it as a losing of an internet bandwidth. You don't notice until you have crossed a threshold. There is also a functional reserve, that is, the brain is remarkably adaptable, and the surviving neurons increase their activity when there is some damage, and the neuronal circuits reorganize to maintain the function. This reserve capacity marks the earlier damage as well. So there is also a measurement mismatch as well. We use different tools to measure the structure and function. As Manju said, we can use OCT, visual field test, etc. So this comes into play here. The OCT detects tiny structural changes in the nerve fiber layer in the earlier stages. Visual field tests are noisy and slow to changes. So the structural changes can be visible years before the functional loss is measurable. There is as well a non-linear relationship between the nerve loss as well as the vision loss. Studies suggest that up to 25 to 40% of the nerve fibers may be lost before the standard clinical tests detect the vision loss. After the tipping point, suddenly the vision declines rapidly with additional nerve loss. This is why early detection is crucial. So in short, what is tipping point? It is a glaucoma refers to a critical threshold of structural nerve damage that once crossed leads to a rapid decline and clinically detectable loss of functional vision. That is visual field defects. Identifying this point is primarily done through a combination of the structural test as well as the functional visual test with current technology allowing detection of structural changes before the functional changes is apparent. What are the key methods? As I told you earlier, the OCT. In this imaging technology is crucial for detecting the structural changes, which includes the retinal nerve fiber layer thickness as well as the ganglion cell inner plexiform layer thickness. The tipping point threshold studies have identified approximately average RNFL thickness of 75 micrometers as a common tipping point. When the average RNFL thickness falls to this level, representing up to 17% loss of the age-matched normal value, visual loss becomes more apparent. How does the OCT indicate the tipping point? It detects the earlier structural damage. OCT can identify and quantify damages to the RNFL and structure like ganglion cell often before the patient even notices it and shows a lag in the function. There is a period in the OCT can show structural damage but visual fields does not show any changes. That is normal results. Identifying the tipping point is very essential. And it provides a benchmark for progression. Once this tipping point is passed, the rate of visual field loss accelerates. So the OCT can help monitor this progression more effectively. There are certain limitations for this tipping point and beyond. A conflicting data is that if an RNFL is very thick or very thin, there can disconnect between the OCT and the visual field changes even around the tipping point. For example, a ceiling effect, that is very thick RNFL. In healthy eyes or a very early glaucoma, there is a large reserve of nerve fibers. Significant changes to the damage to these thousands of fibers must occur before it is detected by a standard visual field, as remaining fibers can compensate, as I told earlier. The OCT may show a thick, healthy reading while early functional loss is just beginning to appear on a sensitive VF test. The other one is the floor effect. That is due to the very thin RNFL. In advanced glaucomas, the RNFL is severely atrophied. It approaching the floor effect where nearly all fibers are gone. And even substantial loss of this remaining fibers doesn't register. It doesn't register a significant change in already minimal OCT measurement. However, this subtle ongoing loss still translates to noticeable progression defects on visual field tests. These are the two limitations of a tipping point. So this is an example. As you can see, there is a diffuse loss of RNFS in advanced glaucoma demonstrating floor effect, and the ST will not be using a stage of disease. When an individual has an unusually thick or thin baseline measurement due to natural variation, tipping point often shifts, as I told you, in the floor effect and the ceiling effect. This highlights the importance of using both structural and functional visual tests for managing conditions like glaucoma, as neither tests tell the complete story alone. We have to use both of this. So as I told earlier, this visual field test is there, which is a checks for blind spots or area of reduced sensitivity in our vision. Earlier stages, in the early stage, visual fields often appear normal or highly variable because of visual system have redundancy. Beyond the tipping point, once the tipping point is reached, functional damage progresses more rapidly and becomes consistently detectable on this test. Then comes the guided progression analysis softwares. Both OCT and HFA devices utilize software like GPA to track changes over a time. Trend and event analysis. The GPA reports look for both gradual rates of trend changes, trend analysis, and a significant confirmed changes in a specific location, that is event analysis. A combined approach is usually needed. This is a small picture of the GPA. So identifying the tipping point helps. How does it help a clinician diagnose the glaucoma earlier, guide the treatment decisions, monitor effectively? Diagnose structural changes can show damage years before the functional loss appears on the standard visual tones, and guide the treatment, that is more aggressive treatment. Example, lower target IOP may be necessary, and you can do it in a younger patients and nearing the tipping point to preserve remaining normal vision for their lifetime, and monitor effectively. That is, monitor to mild to moderate cases primarily with OCT while relying more on the visual aids in advanced cases. This is very important. There are several comparative studies for the existing methods. Several strategies have been proposed to address the individual's ocular factors in interpreting the relation between the structural and functional measurements. The compensation model incorporated various demographic variables to establish multiverse normative value with the compensated RNFL outperforming the measured RNFL. These are several studies. Montego et al. Suggested proportional change based on normative value derived from regression model, prompting progressive future studies comparing with the approaches and the proportional changes comparison and direct measurements. These are other studies that I have taken. So why understanding the tipping point matters? It helps the clinicians use it to diagnose glaucoma earlier, start treatment for the functional damage occurs, track disease progression more accurately, decide when to escalate the therapy, and how the researchers use it. It improves the biomarkers, it develops neuroprotective therapies as well, model disease progression more precisely. These are my references, and thank you.
Thank you, Dr. Soumya, for that excellent talk. Now I invite Dr. Sweta K. She is working as glaucoma consultant in Jyotis Eye Care, Kannur. She'll be explaining central clues, macular involvement, and functional footprints in glaucoma. Over to you, Dr. Sweta.
Thank you, Dr. Manju. Warm good morning. I'll be talking more on the central clues, macular involvement and its functional footprint in glaucoma. Generally, when we talk about glaucoma, we tend to look at the disc and the RNFL. Now, I would like to you all to shift your focus a little bit to the macula. So, why look at macula in glaucoma? We know that macula is important for it because once it is affected, it can affect the quality of vision, the reading speed, the contrast sensitivity, and almost all the daily function. So just an anatomy refresher, we know that when the light falls on the fovea, it goes through the RPE, the bipolar cells, the ganglion cells, and this comes out as the retinal nerve fiber layer into the optic nerve head. So 30 to 50% of all the retinal ganglion cells, it is present in the macula. And this parafoveal retinal ganglion cells are really thick and it is easily affected by pressure changes and can get affected in glaucoma. So this is the area where we are going to focus on. So central damage do occur earlier than we think. It is not that traditionally what we saw, the peripheral, glaucoma is a peripheral disease. No, macula can also get affected. So these are the fibers, especially the macular fibers can get affected in myopia, normal tension glaucoma and some of the early glaucomas. So coming to the structural clues, I'll be focusing on both the OCT and visual fields. The OCT which I'm going to show is a spectralis OCT, and here the spectralis OCT, it can show all the 10 layers of glaucoma, all the 10 layers of retina separately, and what we are interested is a ganglion cell layer which will be shown separately. And we know that the optic nerve fibers are arranged, how it is arranged in fundus. And when we take a visual field, this is the octopus visual field. Octopus visual field, we have the G program, and these points are arranged in the same pattern as this retinal nerve fiber layer. So we have this 10 degree, if you see inside the 10 degree, you have so many points here. The central 5 points are there exactly at the macula, and surrounding that we have these many points. So when we take the G program, it can focus more on the macula. Also macula test patterns, if you see the M pattern, 45 central points, we have dense points and 36 points are there surrounded, or we even have the 10-2 program, which is but equally spaced. In Humphrey's field, we have the 24-2C program, which already Dr. Manju has shown. You have 10 extra points in the center in 24-2C program. So now I would like to show what the normal ganglion cell layer looks like in a normal people. You have a regular donut shape pattern. This is a normal GCL. So when you have early glaucoma, the early red flag signs, what you have to see is this breakage of this donut pattern, the small break which you see here. That is the first sign that something is going on. And even the hemisphere asymmetry, which is given in the retinal layers, you can see that superiorly there is some asymmetry from the inferior area. So this is a patient who was diagnosed with a normal tension glaucoma. You can see that superior rim is also thinned out. The RNFL is slightly thinning, and the ganglion cell layer I have already shown. So this patient, when I saw the octopus field, you can see that the central 10 degree is where it is affected. It's not in the periphery. It's mainly the central 10 degree. You can see the inferior. This will be clearly shown in the cluster analysis. If you take the cluster analysis, you can see that little darker shade, 6.2, that is where. So you can see this here, superior RNFL is, there is a small RNFL thinning there. Now coming to the moderate glaucoma, this is some typical, whenever you are seeing the established glaucoma cases, the ganglion cell layer will look like this. That will be a snail shell pattern, what you see, and you can see the hemisphere in asymmetry. Inferiorly, that will be, it will be shown. And the deviation map, if you see, ganglion cell deviation is the first which you see, and the second is the RNFL deviation. So visual fields, when you take, it will have a superior arcuate scotoma. You can see that it is definitely involving the central 10 degree. Now, I would also like to shift your focus on the advanced glaucoma. Generally, when we say advanced glaucoma, we say that we cannot use OCT. You get an RNFL floor defect. And even visual field changes when you see there will be a constricted field. It will be difficult for the patient to do the visual field. But if you see at the ganglion cell, both of these patients are 0.9 cupping, and RNFL is definitely having a floor effect. So if you see the first patient, the ganglion cell, you can see little bit of ganglion cells in the nasal. The 30, 36, 32, 34, that green yellow area is where we have to concentrate. If you have something like this, you can be sure that if you're going to operate this patient on, he's not going to lose his vision. He will retain the central vision for sure. This is something which I definitely use whenever I pose these patients for trabeculectomy. But the second patient, the ganglion cell is totally lost. Those patients, it is little risky. So not only that, you can use, so if you see the deviation map, it will be like this. And fields will be like this, but we know that elderly patients doing field is really difficult in such cases. And also look at the amount of GCL left. And this can be even used for progression. I say this progression, it may not be seen evidently in the other. If you see the values here, 46 and 50 there, and the second one 41 and 48, the spectralis actually has an anatomic positioning system which exactly takes the scan, the same area the next scan also. So this will be the exact area which is going to get scanned. So even these slight changes, we can be sure that something is going on. We need to alter the treatment. So this may not show the, even here inferiorly, if you see 43, 35 and 41, 33, this is a very subtle change. I do not say that this is a very significant change which you are going to get in as a progression change in a visual field or OCT, but definitely given time, it is going to give that flat map, the downward slope in field. And you have something here which shows this red area which you see, the superior and inferior, the RNFL fibers, this shows the change. There is some thinning happening. So you can use all these things to monitor, to get a flat, this is an RNFL thickness progression analysis. To get something like this, there should be a significant change. But what I'm showing is something which is even before this. We need to always detect it a little more earlier. Also, you can use a asymmetric map between right and left. So what I would like to stress is have a systematic approach. You have to see the rim, you have to see the RNFL as well as a GCL. You get a GCL change, no RNFL change, that is not going to be glaucoma. You see an RNFL change, no GCL change, that is also not glaucoma. All three together has to be there. And also this can also be used for detecting whether it is definitely glaucoma or not. In this particular example, you can see the temporal RNFL fibers are thinned out, and GCL pattern you see like this. It is actually generalized thinning of GCL. If you take the deviation map, you can see that papillomacular bundle is affected and the GCL is also affected. This is not glaucoma, it is something other than glaucoma. You have to evaluate for that. But if you have ERM and some macular conditions, you definitely can't go and check for the macular. So finally, I would like to say that don't stop at the disc, don't stop at the RNFL. Look forward and see the glaucoma, GCL also. Especially this is important when you have a myopic cases where you can't get a proper RNFL. You don't get an idea. You go look ahead at the GCL. It definitely gives you an idea whether this is glaucoma or not. Thank you.
Thank you, Dr. Shweta, for that excellent talk. Now I invite Dr. Manju Anup Madam, who is working as glaucoma consultant in Giridhara Institute, Kochi. She will be talking on dual diagnosis, merging structure and function for confident clinical decisions. Over to you, Madam.
A very good morning to all, and thanks Manju for the invite. I am supposed to talk on merging the structure and function for confident clinical decisions. I think most of the points are already covered and made it easy for me. And as you all know, the two important features in glaucoma include the structural damage to the RNFL, GCL, and the functional loss in the field of vision. So now what is the relationship between the structural and the functional changes in glaucoma? Whether the structural changes occurs first or the functional changes occurs first and both are present simultaneously, or can we use the presence of either structural or functional changes alone to make a diagnosis and assess the progression? So this slide on glaucoma continuum shows that the structural loss often precedes the functional loss by years. Significant ganglion cell loss occurs before it's detected on standard automated perimetry. This slide also shows that in the early disease, the visual field has a ceiling and OCT is more sensitive in the early disease. However, in advanced cases, OCT has a floor effect and the visual field is more sensitive for the analysis of progression. Also, we can use the GCL analysis in the advanced disease. But in moderate to severe glaucoma, both the structural and functional changes will be there and it shows a linear relationship. This is Garvey-Heath sectorization, which shows the relationship between structural and the functional damage. When you have a superiotemporal damage of the optic disc and the RNFL, you will get an inferior arcuate defect. And when you have an inferotemporal damage, the field defect will be superior arcuate. So now the next question is, does the structural change always precedes the functional damage? As previous speakers already told, in pre-perimetric glaucoma, you can have structural damage without a functional damage. And also sometimes you can get the visual field defect without a structural damage, especially in media opacity, non-glaucomatous causes, and in small paracentral defects missed by the RNFL circle scan. However, in most of the cases, you may be able to get both the OCT and the perimetric changes. And also the progression rates are different for perimetry and OCT. So relying solely on one modality leads to a delayed diagnosis or misprogression, and merging them provides more complete and accurate picture. Now you have combined indices to make it easy for the physician. You have combined structure function printout and guided progression analysis. This is the structure function printout which is already explained. You have the visual field changes. You also have the OCT, RNFL, GCL changes, and you can include the fundus picture also in this, and everything will be given in the same printout. And in the center, you can see the structure function correlation. Here the OCT RNFL changes are flipped for the comparison. So here there is a superior arcuate defect and the red area is the inferior RNFL defect. This is the guided progression analysis printout of the Humphrey. You get a trend analysis and also you will get an event analysis which shows likely progression or the possible progression. This is guided progression analysis of the OCT RNFL and this one is the GCL. So now let us look at some case scenarios. The case one is a 65-year-old male with no significant risk factors. Presented for a routine eye checkup and on examination fundus, the right eye was showing an inferior NRR thinning with corresponding RNFL defect and the left eye is relatively okay. And we did an OCT which picked up that inferior RNFL thinning and also the GCL is showing the inferior loss in the right eye and the superior left eye shows a superior small RNFL defect and also an early GCL loss. When we did the fields, it shows a dense superior arcuate defect in the right eye and early defect in the left eye. So in this case, you have the structural changes and corresponding functional changes also. So there is no doubt in this. This is a definite glaucomatous damage. And whether this is the combined printout of the same patient and whether you want to start treatment or not depends on the other factors and I'm not going into the details of that. Case 2 is a 63-year-old female who again came for a routine evaluation. On fundus examination showed inferior notch with an inferior RNFL defect in the right eye and the left eye was relatively normal. And you can clearly see the RNFL defect here. And however, the perimetry was relatively normal, but in the pattern deviation, there was some scattered defects, but the total deviation was completely normal. So we cannot rely much on this. The OCT picked up this defect. It shows the inferior RNFL defect and also the GCL is showing the inferior loss. So in this case, you have a structural damage, but which is not picked up by the functional changes, that is perimetry is relatively normal. So again, this case, you may need a frequent follow-up if the intraocular pressure is normal. Otherwise, you may need to start treatment because it can be a preperimetric glaucoma. Case 3 is a 56-year-old female who has a known case of primary angle closure post-PI with this suspect. This was the picture in December 2023, which is showing an inferior RNFL defect in the right eye and the left eye is relatively normal. So on recent follow-up in July 2025, clinically the RNFL defect and the disc looks almost the same. And the field defect was normal in the initial visit also and the latest visit also the field is almost okay, but there is a small defect which is seen in the paracentral area in the right eye. However, the OCT, RNFL and the GCL was showing that defect. When we took the guided progression analysis of the OCT RNFL, it is actually showing a possible progression. And in the GCL, it was normal in the initial 2 years back and now it is showing an early damage. So there is a definite structural progression in this case. So we took a 10-2 and which took up the case, took up the changes. And so there is a definite progression and you may need to think of stepping up your treatment. And the central corneal thickness is also less. This is my last case. This is again a case of primary angle closure disease, post-PI in both eyes. And the right eye is relatively okay. The left eye is showing advanced damage. And this is the guided progression analysis of perimetry, which is in the trend, it is almost normal or stable in the right eye, but in the event analysis, it is showing a possible progression. The left eye has advanced damage, which is almost stable in the perimetry. However, OCT RNFL was showing an early progression. Even the GCL is showing a progression in the right eye. The left eye is almost stable. So here there is a progression in the right eye. So the left eye is advanced damage. You may have to think of stepping up your treatment. So to conclude, a structural defect that matches a functional defect is the strongest evidence of true glaucomatous damage. In pre-perimetric glaucoma, a definitive progressive structural loss is the disease even with a normal perimetry. In advanced disease, shift the primary monitoring to visual field progression and macular GC-IPL analysis. Thank you.
Thank you, Dr. Manju, for that excellent talk. So now we conclude the session. Any doubts from audience? Thank you all.